by Dr. Munnawar Shah, and the topic is revision lethargy procedure. Over to you, sir, please.
I'll tell you what is the importance of Walsall, where I come from. It is because of Walsall we speak English in England and not French. And the reason for that is there was this 200 Anglo-French war, which was culminated in Agincourt. And this is where the French surrendered and decided that no more 200 years wars. So if you can see, so this is the port of Arms of Warwick. So it's in Warwickshire. We live in Stafford, but our door says Warwick Fair. Okay? You just keep that in mind. So what happened was, when important prisoners were caught, they were taken to the capitals and exchanged for money, mostly gold. So the Earl of Warwick was taking prisoners, French prisoners, to London. And when he was in there, Agincourt fell. Right, so which means उसको जो है जो पैसे मिलते थे उसमें से हिसाब नहीं बना उसका कोई, मतलब उसको कहा भाई आप थे नहीं तो किस बात के पैसे मांग रहे. So the battle was won by the longbow archers. Okay, because the place had gone all wet, the heavy artillery of the horses and the armor they were wearing was too heavy, and they all sank into the mud. So the archers kept shooting at them, and they killed over 1,800 noblemen on the same day. Now that's a big loss, and that's why the French lost. But unfortunately, or fortunately for the Earl of Warwick, these bowmen had no affiliation. They were all from Walsall, but they had no coat of arms. So Earl of Warwick ने चालाकी ये की कि उन सबको कहा तुम Earl of Warwick के प्रोटेक्शन में हो, इसका मतलब है तुम मेरे फौजी हो, इसका मतलब है कि जो लूट मार होगा उसमें मेरा भी हिस्सा बनेगा. So we are speaking English because the French lost to the English because of the bowmen. So Walsall can say that we are part of English heritage.
It is even worse than Chichalati.
Because if the conjoined tendon was not managed, it would have been difficult. I'm also lucky that I have allografts available to me, and the tibia plafon anatomy matches the anatomy of the glenoid. So this is the picture open, and I'm not sure whether you can see them or not, but is my pointer there? No. Okay. So basically, sorry, we have time. Let me get time. So this is the soft tissue. This is the little head and the second bone line of the see the screws visible in there. Okay, so this is the more better picture. You can see the graft we put in. You can see a clear gap between the glenoid and the graft. The screws are still there. So we took out the screws first. And this was now without the screws, but the screws were not completely thrown away because the tendon was still attached to it, the conjoined tendon. So what we did then was measure the defect. We had an allograft, which was a tibia. The plafon matches the shape of the glenoid. We cut the appropriate piece that we required. Okay, so that's the missing piece, and that's what we have. This is a special kind of kit, but it doesn't need to be, because what it is the suture goes through the washer, which means you don't have to hook it, it's already there, and you just put in, stitch it, and put the screws in the washer, so therefore it is attached. This is for the soft tissue reconstruction. Okay, so this is the glenoid, which was clean. The bone graft that we had, we put 2 wires in it where the screw should go. We reattached it, or put it near to where the glenoid was. And then we used the suture to bring the conjoined tendon to where it should be. The conjoined tendon was already there. We just cleaned it and tidied it up. Okay, this more pictures getting there. The screws going through the washer to keep it together. Getting closer and closer. Eventually, the last picture shows what it looks like. There's a glenoid. There's a graft that we put in and the conjoined tendon underneath it. This is the check X-ray post up. You should not see the buccal screws, because everybody is human, and I am human more than everybody else, and I broke the screws, but it didn't matter because it was not in the articular surface. But we did maintain to get function to the gentleman, and we also had a nice looking glenoid afterwards. So I have spoken, like I said. My short, sweet presentation here. Questions in the extent.
Yep.
Over to moderators for discussion.
Thank you very much, Mr. Shah and Sufyan. So, first of all, we'll take questions. Anybody wants to ask any question? Dr. Amir? Mic to Dr. Amir, please. There's actually, yeah. Mic. There's actually mic at the back there if you want to go there.
Yeah, it was still attached to the bone. The acromion that we took with the conjoint tendon, it was still attached to it.
And then you took the...
I took the bone that was dead
Yes.
and put my allograft into it. With the sutures I showed you with the washer in it, I stitched the conjoint tendon onto it and reattached to it where
The
the
bone block.
was,
Okay.
yeah.
So, question, there's a lot of audience, the question was, what did you do with the conjoint tendon? As we all know, in letter J, the conjoint tendon works as sling, then there is a bone which is augmented. So, we are question from Mr. Shah, he has experience with revision. What, you know, the way you have the opportunity to see what was the actually conjoint tendon look like when you went in there? Was it the same strength? Was it is gone? Or was it a, you know, what was that bone like which you have to revise like?
So I don't have any way of knowing whether they was good or bad, but it was not used because this was a non-union, so it was not stretched. So it was nearly as normal, like you said.
It was all intact.
Yeah, it was nearly normal.
Sorry, मैं शायद I'm out of touch. ये जो moderators हैं, सवाल नहीं पूछ सकते. बट साहब बात थोड़ा रखो.
No, no,
पहले
no,
audience को
We were only clarifying about the letter J because it make concept. We thought, most of us think the letter J is the word. So far, it is the best operation, one operation, highly stable. In your series, 99% were stable and no infection. The two people were not happy, and you probably have revised for other people. That's why we were only elaborating the question. And from Sufyan, any question from Sufyan? No.
No, I was just thinking, Shah Sahab, that, I mean, how long did you revise this? I mean, what was the duration in?
9 years.
9 years.
9 years.
So, I mean, if you think that the coracoid coming down, conjoint tendon there, lying for 9 years, and now you have to revise it, there was non-union, the bone had not united, how do you expect that the tendon is going to be
Same.
functional? Or efficient, I may say.
No, I accept that. I said I have got no way of telling you whether it was good or bad, but it looked good. So visually, it was okay.
I mean, even if it is visually good, I don't know how come you can manage after so many years to actually bring it down or attach it, reattach it. I mean, it's hard to imagine actually.
So the reason I'm showing this is because we did it. It's not we telling you you can do it. We're telling you we've done it, like, you know. But yes, it is very difficult. It is not easy. And the backing I have is I've been doing it for a long time, so you know what to cut, what not to do, where to stretch, all that kind of stuff. But yes,
So
it is not
whenever
easy.
you have tendinous avulsions, I would say,
Right.
in fractures, so you find neglected fractures, avulsed fractures, if you ever want to, let's say, go in and see them after many years, you will never find a way to actually bring the tendons, other than lengthening probably. That is one method of probably gaining length after so many years. Otherwise, everything contracts and it's hardly functional. And even if you don't reattach it, what difference would it make?
Yeah.
Sorry, can I just answer? In my defense, I didn't do bad but for 9 years for it to work and let him play rugby. So this was a icing on the cake. So if it went well, fine. If it didn't go well, okay. But I have seen him a year after the operation and he was playing rugby. Whether he was good at it or bad as it did, I can't guarantee that, but it did work. So I'm saying it works in everybody's hands or it is a good operation too. I just shared my experience on a failed that today. Yeah.
And then another question comes out of it is that if we can use a bone graft, other than this, that probably it will be a pedicled bone graft if we use the coracoid. why can't we use just a cancellous graft on the very first instance, doing a letter J?
So the answer to that is letter J was not the first operation described for this. There was an English captain, an army surgeon, and he described it first, and he used to take a small piece of graft and just stick it there. Okay, then it was improved by taking the graft from the distal fibula. Then it was improved by taking the coracoid. And then it was improved by making it anatomical and more shapely. So yes, the answer to your question is you can use any bone graft you want. All you want to do is stop the humerus from falling off the glenoid. But fortunately or unfortunately, I live in the first world, and the questions are asked to me, why did you not use this technique when it was available and it is the advancement? So because of that, and because we had a multidisciplinary team meeting, we have 4 surgeons, and we chatted about it, and they said, let's revise it.
Thank you. Mr. Khalid Khan?
Yeah. Hi, Sufyan. Just one question. I think probably I'll be talking on behalf of our residents, and I'm not a shoulder specialist, but coming in my mind, what's your rationale? You described this technique, and you said this is just one technique, but letter J is still you do in most cases. So what's your rationale? How you decide which patient you select for this procedure, which one you do for letter J?
Okay. So I think Sufyan explained it very, very, very clearly.
Sufyan.
Yeah, about where you can do latter J and where you can do soft tissue. Latter J is a very standard procedure. I have done quite a lot of them. It's a revision was my only case that I brought it up because I think just to show what options are available. But there is a clear-cut guidelines. There's a step procedure where you want to do soft tissue, where you want to do bony, and where you want to do bony plus soft tissue. So I think you went through that with your...
Yeah, I know Sufyan mentioned, but practically, say if some patient came.
I come from an area, if you don't follow, do come from the same area.
Correct.
Yeah, thank you.
If you
And
don't follow rules and guidelines, God love you, that's all I can say.
Sufyan, can
thank
we change that this thing to...
Yes, sir.
But Mr. Khalid Khan is saying the algorithm.
Algorithm. Let me
How
talk
you
about
decide which one need soft tissue,
and
which one
needs
latter J with remplissage.
With remplissage. So thank you very much, Dr. Khalid, for putting this question. First of all, I'm very lucky to have my teacher in front of me who is ready to take any questions coming to his students. So I am still an educator of using latter J procedure. So you're talking about the rationale of putting things together. So whenever you see a patient of shoulder instability in your clinic, the first thing that you need to establish is that to identify what are you looking at. Either it is a lesion which is an on-track lesion or an on-track lesion, what intensity of bone loss that you're actually going to see. So first thing is quantification of the problem, that what type of problem is it. Statistically, MRI has actually shown to be coming near equivalent to a CT scan in actually rationalizing the amount of bone loss that you're actually going to see. So you have to put the all picture together in one go to actually answer this difficult question. You have to look at the instability severity score index, how much lax the patient is, what does the patient do as a profession, is he a primary athlete or a non-contact athlete. Then you have to quantify that what is the bony problem of the patient, whether it's it's a glenoid which is at more loss or the humeral head which is at more loss. So according to that, you come in you have to classify this rationale into 4 typical type of classifications that are there in the literature that has been reported, and for the generations of younger budding sports surgeons and also the residents coming up, there are 4 classification systems that you have to come up. You can see in which the glenoidal bone loss and humeral head defect has been quantified on a certain criteria. I have shown that in my talk, and if you see that the lesion it's an off-track lesion, the glenoid is less than 20% of a loss. By quantifying it on the table, working with your radiologist, working on mathematical formulas, you have to develop all of it inside your clinic by looking at the patient. Only then you will be able to quantify what problem are you looking at. So depending upon all this quantification, if the glenoidal bone loss is less than 25, it's an off-track lesion, meaning that the humeral head is still engaging, but the humeral head lesion is very small. The patient is a non-contact sport athlete, and it is desirable for an arthroscopic procedure to be done. Only then I offer them remplissage in my clinical practice. Other than that, working on a lateral J, I agree, lateral J is a safe, efficient procedure, but not to be done in every sort of cases, because as Mr. Shah has actually said, that revision is another game. You can easily go and revise your remplissage and Bankart to a lateral J, but what will you do if a lateral J fails? And these are the problems, finding the conjoint tendon. And for residents' perspective and for sports surgeons, lateral J give you stability by 3 factors. Conjoint tendon is one of them. If you lose one of those factors, even if you're not able to find that, it's very difficult to find that, but if you are very lucky, you will be able to find that. If you're not able to find that, then you're looking at a classic Eden-Hibernite procedure that was explained by a French surgeon in 1912. Only bone is there, and he was genius enough to analyze that the defect will not engage onto the anterior aspect, but it will glide ahead. So it will not be an engaging sort of a lesion, and that all has been quantified by the ETOI in theory of glenoid tract, and this is something that every resident and every sports surgeon should be knowing how to quantify and what to offer when to the patient. I hope I've clarified your answer.
सिंपल तरीका ये समझना कि जो ह्यूमरल हेड है वो जब डिसलोकेट होता है और वापस आता है ना, तो इस तरह वो लगता है पीछे ग्लेनॉइड के रिम के साथ, तो उसमें से पीस निकलने लग जाए। वो छोटा होता है, बड़ा होता है और गड्ढा हो जाता है। तो जब छोटा वाला होता है ना, तो यू कैन डू द सॉफ्ट टिश्यू प्रोसीजर। जब बड़ा हो जाता है, देन यू हैव टू मेक श्योर that big defect does not fall into your tract. Now you can do that by a remplissage at the back. You stick tissue into it, so it stops it from going where the defect is onto the glenoid. Or you make such a big place for it that the defect cannot get engaged anywhere and just moves across it, glides across it. That's the theory, the simplest way. Are we finished now? Yeah, sorry.
Thank you.
Okay, so I just want to make a step. Everybody comes in and thanks the organizers for being invited. Mine is different. I actually forced invite myself to ask them that I am free and can I come? And I did get no answer from Shams, but Aurangzai Saab facilitated it. So thank you very much, sir, for asking me to come here.
Thank you.